All right, let's cut the fluff and jump straight in. This explainer is a brutal, high-yield simulation specifically designed to push your clinical diagnostic skills into that elite 270-plus percentile.
We're running a mixed block simulation focusing on pediatric musculoskeletal emergencies. I want you to expect intricate mechanisms, incredibly high-noise distractors, and frankly, zero room for error. We're keeping this strictly peer-to-peer and professional. Your objective today is simple: identify the trap, find the clinical trigger, and execute the surgical mandate. Let's go.
First up, the inflammatory matrix. Your immediate clinical challenge here is rapidly distinguishing the destructive bacterial seeding of septic arthritis from the benign post-viral inflammation of transient synovitis. This is absolutely crucial because one of these will literally destroy the joint cartilage within days, while the other, it resolves with just simple supportive care. Now, the presentations are almost identical, so how exactly do you split them?
Well, the crucial differentiator is the Kocher criteria. You have to lock in these 4 strict predictive markers. 1. Non-weight-bearing status. 2. A temperature spiking over 38.5 Celsius, which is 101.3 Fahrenheit. 3. An ESR over 40. And 4. A serum WBC above 12,000. Hitting 3 or more of these criteria dictates a massive probability of a septic joint.
So what happens when those criteria actually trigger? The clinical pathway locks in. The mandatory next step is an urgent ultrasound-guided synovial fluid aspiration. If you pull fluid and that synovial WBC count comes back over 50,000, you've just confirmed septic arthritis. That mandates immediate surgical washout and IV antibiotics. No exceptions.
Okay, let's put that threshold to the test. Imagine a 5-year-old patient with a recent upper respiratory infection. They present with a limp, a fever of 102 Fahrenheit, and an ESR of 55. Evaluate the matrix in your head. What is your definitive next step? A. NSAIDs, B. Observation, C. Plain radiograph, D. Urgent US-guided joint aspiration, or E. Outpatient oral antibiotics. Lock in your answer.
This brilliantly illustrates the classic board trap. Our patient has a limp, a fever over 101.3, and an elevated ESR. That is 3 positive Kocher criteria right there. Choices A, B, and E, NSAIDs, observation, or oral antibiotics, are lethal conservative traps that will literally cost this child their joint. Choice C, a plain radiograph, simply delays definitive care. The clinical triggers force you to choice D, urgent joint aspiration.
Notice the variance here. An identical presentation diverges entirely based on crossing that strict Kocher threshold. Less than 3 criteria, you're likely looking at post-viral transient synovitis, and you can safely monitor them. But 3 or more, you must assume it's a septic joint and aspirate immediately.
Moving on to epiphyseal disruptions. Let's look at how mechanical forces and ischemia differentiate 2 major pediatric hip pathologies: slipped capital femoral epiphyseus against leg calvé-perthes disease. SCFE occurs in obese adolescents due to excessive shear stress across a weakened physis. Leg calvé-perthes, on the other hand, represents idiopathic avascular necrosis of the femoral head, typically striking younger boys between ages 4 and 10 with a really insidious antalgic gait.
When you look at the imaging, the contrast is incredibly stark. With SCCFE, you can clearly see the acute shear displacement. It's like ice cream slipping off a cone. The metaphysis has moved anterosuperiorly relative to the epiphysis. Contrast that with leg calvé-perthes, where you'll notice chronic ischemic flattening and fragmentation of the femoral head.
You absolutely must respect the surgical mandate here. SCFE is a true orthopedic emergency. The second you suspect it, you make the patient strictly non-weight-bearing. The treatment is immediate prophylactic surgical pinning in situ. Any hesitation risks catastrophic avascular necrosis.
Let's run the next assessment. A 13-year-old obese male presents with chronic knee and thigh pain, an altered gait, and obligatory external rotation of the hip. What's the most appropriate treatment? A. Physical therapy, B. NSAIDs, C. Cast immobilization, D. Surgical stabilization of the femoral head, or E. No treatment.
The option matrix here forces you straight to choice D, immediate surgical stabilization. This patient is presenting with classic SCFE. Choices A, B, and E are those non-surgical traps geared toward overuse injuries or non-inflammatory arthropathies. And choice C, cast immobilization, that's totally irrelevant and inappropriate for SCFE. It's used for specific non-surgical fractures.
And this brings us to a classic trap that catches literally so many clinicians off guard. Knee pain in an adolescent. is very often referred pain from a devastating hip pathology like SCFE. An altered gait with isolated knee pathology might point to something like Osgood-Schlatter, sure. But the moment you see external hip rotation coupled with thigh pain, your diagnostic focus must shift entirely to the hip.
Let's shift gears to hematogenous osteomyelitis. In children, bacterial seeding primarily localizes to the highly vascularized metaphysis of long bones. The sluggish blood flow in these metaphyseal loops creates the perfect quiet microenvironment for pathogens to settle down, multiply, and completely destroy the bone marrow.
Now, while Staphylococcus aureus reigns supreme globally as the dominant pathogen for osteomyelitis, you have to know the exception. Patients with sickle cell disease harbor a highly tested, specific vulnerability to Salmonella species. Why? Because recurrent microvascular occlusion leads to functional autosplenectomy and gut mucosal ischemia, which basically allows Salmonella to translocate right into the bloodstream and seed those bones.
Advanced imaging, like an MRI, is fantastic. It's highly sensitive for detecting marrow edema early on. But the diagnostic rule remains absolute. You must perform a targeted bone biopsy to definitively isolate the pathogen before you commit a patient to a prolonged, multi-week course of systemic antibiotics.
Let's evaluate this third-order presentation. A pediatric patient with sickle cell disease presents with focal tibial pain, fever, and a falsely reassuring normal plane radiograph. What is the definitive next step to save this patient's limb? A. PO ciprofloxacin. B. PO ibuprofen. C. MRI, targeted biopsy, and empiric dual coverage. D. Contralateral X-ray. Or E. IV ceftriaxone without biopsy.
Choice C is literally the only path forward. Plain films are often negative early on. You must secure the MRI, obtain the biopsy to isolate the organism, and then immediately cover empirically for both Staph aureus and Salmonella. Choices A, B, and D dangerously delay care. And choice E? That violates the fundamental rule of securing a biopsy before making a long-term antibiotic commitment.
The defining factor in this variance relies entirely on the status of the patient's spleen. A healthy pediatric bone gets empiric Staph and MRSA coverage. However, an asplenic sickle cell patient demands an immediate expansion of that antibiotic envelope to cover gram-negatives, specifically Salmonella. You always have to tailor the pharmacology to the precise pathophysiologic deficit.
To close out this explainer, let's look at one final high-stakes trap regarding pediatric joint effusions. A 1-week-old neonate presents with fever, irritability, and a swollen, painful joint. You perform an arthrocentesis, and it yields purulent fluid. What organism is destroying this neonate's joint? A. H. influenzae. B. Listeria. C. N. gonorrhea. D. Shigella. Or E. S. aureus.
The answer is E. Look, don't overthink the neonatal demographic here. While other pathogens like Group E strep or Neisseria gonorrhea are definitely tested exceptions, Staphylococcus aureus remains the absolute most common causative organism for septic arthritis across the board, even in neonates. Commit that fact to memory, trust your algorithms, and you're going to absolutely dominate the wards.